Very good evening to all the participants who've joined for this webinar today. From the side of MedGenome Labs, I welcome you all to this interesting session today. On the occasion of Breast Cancer Awareness Month, this is a small effort from our side to just create a little bit of buzz and awareness about a very uprising issue in India, which is about women healthcare, mostly focused on breast cancer. So, with the presence of very esteemed speakers today, we just want to help and understand everybody about rising, cases about breast cancer in India, and also give a little bit of information that can be useful for improving the work in the preventive oncology space. So, firstly, I would like to introduce Dr. Jyoti Bajpai. It is our esteemed pleasure to have today her presence in this webinar. She is the leading medical oncologist and pioneer in precision and oncology and immunotherapy. She has completed her MBBS from AIMS, New Delhi, and also has advanced observership from world-renowned institutes like Memorial Sloan Kettering and in bone tissue and sarcoma and at John Hopkins University School of Medicine. She's currently leading the medical and precision oncology for Mumbai and Maharashtra region at Apollo Hospitals and also a visiting consultant at HN Reliance Foundation Hospital and Research Center. So basically, her all expertise lies in immuno-oncology, precision medicine, and rare cancers, including sarcoma, skin cancer, breast, and gynecological malignancies. She has published over, there is no number, mostly about over 200 papers, contributed to major international guidelines. So please join me in welcoming Dr. Jyoti for giving us some enlightenment about hereditary breast cancer. So, ma'am, over to you. Thank you so much for your time today. We look forward to having a great session. Thank you.
So thank you very much, Dr. Bahal and entire MedGenome team for this, this all efforts. I think it is really important to discuss these topics. And let me share my slides. So in next few minutes, we shall be talking about understanding hereditary breast cancer beyond BRCA, which is extremely important because, many times, this is a misconception that, everything is like BRCA. However, there is beyond BRCA also, which things are there, which we need to really know. This is my humble introductions, which Dr. Bahal already introduced. I'm currently working at Apollo Groups of Hospitals, and I'm as a full-timer at lead medical and precision oncologist and at HN Reliance Hospital as a visitor. So this is a human genome, a human body. There is, there is cell within that chromosomes, within that DNA, gene, nucleotide, etc. And a chromosome is essentially made of tightly coiled DNA. And a gene is a specific segment of DNA that codes for a protein. And DNA itself is composed of repeating units called nucleotides. So this is just to a recap, a quick recap. There might be a couple of students as well in the audience. So these are the basic concepts of cancer that, if there is a one mutated gene already present and one normal gene, then there is another hit and then tumor develops. So hereditary causes accounts for in and around 10% of cancer cases, and an estimated 20% of cancer patients have a family history of cancer. So this is a sporadic, variety of cancer, and the green one is inherited. And we can see here that generally sporadic, a later ages of onset, 60s, 70s, little or no family history, single or unilateral cancers, while it's inherited at generally early age of onset, multiple generations with cancer, there are multiple or bilateral cancers, and there are certain syndromic associations like breast, ovarian, etc. So we can see that there is there is a mechanism of cancer predisposition. We see sporadic cancer. Generally, it is late onset, while in hereditary cancer, the same things happens early. So if we compare in a tabulate form, the genetic versus hereditary, by definition, genetic involves genes or DNA, while hereditary essentially which passed from parent to child. Origin, it can be acquired, somatic, or inherited. Genetic one, or all heredity is always inherited, understandably. And inheritance, in genetic, it's not necessary, while in heredity always. Example of genetic is TP53 mutation, which may be somatic, while hereditary, maybe we can give an example of BRCA1. Clinical implication, we can use in genetic some guided targeted therapy depending on what abnormality we are finding. And here in hereditary, depending on the abnormality, we can guide therapy as well as we guide prevention, screening, and family cascade, depends upon what we are finding. So germline BRCA mutations can cause cancers in many organs. They can be 45% of BRCA mutated women develop CA ovary, 55 to 60% develop CA carcinoma breast, and different series give slightly varied incidence. They can be, apart from breast and ovary, it can be prostate, pancreas, it can be renal, colon, stomach, fallopian tube, so on and so forth. So this is very important as far as these inherited cancers are concerned. What about the features of hereditary breast cancer? Generally, the premenopausal breast cancer diagnosed before 50, many times before 40 as well. In my Tata Memorial Center's efforts with young breast cancer, we find that our incidence of young breast cancers is quite high than in Western world, almost double. And also, generally, because of our heavy, younger age pyramid, heavy bottom, we see 1 decade earlier in general other cancers as well. So multiple primary cancers in the same individual, several women in the family with breast cancer, multiple generations affected, maternal or paternal lineage, male breast cancer in the family, associated ovarian cancer cases, triple negative breast cancers, Ashkenazi Jewish ancestry. There are also high incidence of BRCA1/2 found in mutation. So if we see, large majority of cases still are where the genetic mutations are not known, somewhere around 85-90%. And among the remaining cases where breast cancer cases with known mutation, the predominant one are BRCA1 and BRCA2 with almost 30%. And then there can be others like CHEK2, PTEN, ATM, P53, CDH1, Lynch syndrome, PALB2, STK2, BRIP1, and others. So there are some highest genes associated with breast cancer. We can see here that there are BRCA1, BRCA2, and TP53, the Leaf-Romani syndrome. So in BRCA1, the absolute risk is 60 to 72%, and we generally recommend on screening with annual MRI plus mammogram alternate from age 30. And also we say that it should be younger than when that family starts showing, if there is a history in the family that somebody is already affected, then we generally start with less than that age, or 30, whichever is younger. Evidence is really strong. Ovarian cancer around 39 to 58%. There can be risk reducing Salpingo oophorectomy at 35, 40, or again when the family is completed, or when the first case, if the first case is even at 30, then we have to be even more cautious before that also. Other cancer risks are pancreatic, prostate, and evidence is strong. BRCA2 slightly lower than BRCA1, but still it is quite significant. Again, the screening recommendations are similar as for BRCA1. And again, there is ovarian cancer risk also associated, slightly lower than what in BRCA1. Again, there is pancreatic, prostate, and also melanoma risk. TP53 preferred over mammogram. There is no consistent association of ovarian cancer. There can be other cancers like sarcoma, leukemia, adrenal brain tumor, and we suggest them to avoid radiation exposure. The moderate risk gene is like ATM, CHEK2, and PALB2. There is a slightly lower risk, somewhere around 20-25%. And ovarian risk is somewhere around 2 to 3% in ATM. And pancreas prostate also is around 5 to 10%. CHEK2, 23 to 27%. Ovarian not really associated. Prostate, there is emerging evidence. PALB2, significant 32 to 58%. And screening recommendations like BRCA1 are recommended, and ovarian comparatively less, but still around 2 to 10%. And pancreas also are almost similar. And the other genes with emerging evidence like CDH1, BRIP1, BARD1, CDKN2A, HOXB13. So in the early breast cancer setting, upfront knowledge of BRCA status may inform decisions around surgery and targeted treatment. So, If there is a BRCA mutation, which is fine, generally they are more aggressive phenotype than sporadic disease, and they require a treatment plan that targets underlying biology of the disease, and there is high risk of recurrence, and also it merits preoperative genetic testing. And if it is found to be BRCA, then we can use olaparib treatment, which is having quite value. There is suggestion for using platinum-based therapy also, which is again of significance. So if BRCA status, the evaluate addition of platinum compound, discuss new or adjuvant PARP inhibitors, discuss prophylactic salpingo-oophorectomy and even mastectomy, depending upon patient to patient. Consider, and adapt follow-up. So there is a clinical utility of universal germline genetic testing for patients with breast cancer. And this is a very important paper published in German Network Open. And this shows that, if all patients with a breast cancer diagnosis beyond those currently recommended by NCCN guidelines benefit from multi-gene germline genetic testing, and clinical recommendations were changed for 68% of patients who did not meet the criteria for testing according to previous non-universal guidelines, but were found to have pathogenic variants in cancer predisposition genes. Clinicians consider testing beneficial for 2/3 of patients with pathogenic variants, like gene-based therapy, and for 1/3 with either negative results or variant of uncertain significance. For example, we can de-escalate surgical intervention. So these findings suggest that restrictive criteria for germline genetic testing deny data-informed clinical management to patients with breast cancer, and hence it is suggested that universal germline testing is more beneficial. There is a North Indian BRCA germline testing data with 236 good number of patients, and Mittal et al. Has done this study, and they suggest that the prevalence of pathogenic mutation in breast cancer patient is higher in Indian patient compared with most other population. It's a very significant finding. And testing by NGS is recommended at a centralized CAP and or CLIA certificate laboratory for all patients, followed by reflex MLPA for all patients if negative by NGS. And pre and post genetic counseling is mandatory. And here, suggestions, all patients irrespective of age and family history needs to be tested. Then there is another major Indian germline studies for hereditary breast cancer from Singh, from Mittal et al., from Kadri et al., from Pramanik et al. And we can see that generally there are key non-BRCA genes are also detected. There are BRCA share versus non-BRCA. BRCA is like in Singh et al., it's 85%, while non-BRCA 15%. In Mittal, BRCA 66% with non-BRCA 34%. In Kadri, BRCA 88% versus 12% non-BRCA. And cities, essentially these all suggest that we need to, there is, although BRCA still predominates, but other mutation also present, and we have to be cognizant about that. And also it summarizes Indian patterns, non-BRCA proportion increases with broader panels. So what is the overall Indian experience? BRCA1, 2 dominates the finding, 65 to 85%, but non-BRCA genes account for 12 to 34% when broad panels are used, most often PALB2, TP53, ATM, CHEK2, with sporadic, BRIP1, RAD51, CD, etc. TNBC is an early onset enriched for BRCA and Indian studies. Unselected North India consecutive cohort still showed 18.6% PLP with 1/3 non-BRCA, arguing for panel testing beyond BRCA. So overall, Indian PLP yields in BRCA in breast cancer cohort is like 18 to 30%, depending on selection, and highest in HPOC or TNBCs or young, lower in unselected ones. So I will just show a quick real-time case example, because I think Tushar will be discussing the case studies. So this particular patient, wherein 64 years, with ovarian cancer at 62 years, and high-grade serous. And then we are seeing BRCA1 mutation, and then we are seeing that there is a breast cancer at in the family at 38 years of somebody, another person is affected at 70 years, another person is affected with breast cancer. There's another person who's breast cancer 42 years, and one more 60 years ovarian cancer. So here, after primary debulking, cytoreductive surgery and germline panel testing, adjuvant chemotherapy, there was CR achieved. Generally, these BRCA, BRCA positive patients, they respond good to platinum. And then first-line maintenance therapy, olaparib, 2 years, we can definitely benefit these patients. So cascade testing led to early detection. There is a pathogenic variant was detected in BRCA1 gene by NGS. So this is an asymptomatic individual, family history, mother had breast cancer, two maternal aunt variant, one aunt found to harbor a pathogenic variant in the BRCA1 gene and a variant of unknown significance also in FANCD2 gene. So while testing this carrier, we found this is a carrier as well. And during the annual screening mammography, she was detected with 1.5 centimeter mass on right side, TNVC histology, and currently undergoing therapy. So we could detect early this patient and plan for appropriate treatment. The pathogenic variant causative of the reported phenotype was detected. This is BRCA1, exon 10. So a heterozygous nonsense variation in the exon 10 of the BRCA1 gene that results in a stop codon or premature truncation of the protein at codon 1203 was detected. And this observed variation has previously been reported in breast and ovarian cancer patients. So the variant is documented as pathogenic in hereditary breast or ovarian cancer syndromes and CLENVAR database. So that's how we interpret, and it is meaningful. There is so this is again the North Indian BRCA germline testing data, which again suggests that all patients, irrespective of age and family history, needs to be tested. And that's how we can detect more and more cases and can appropriately treat. So right now, it is not only having a predictive potential, but it is also having therapeutic relevance. Hence, it merits that we should test and detect them early. If there is a positivity, then we can do a family testing depending upon their age, etc. after a proper genetic counseling. And then if we find them, then there are appropriate measures which can be taken. So it's extremely relevant. So with this, I would thanks, and I will hand over to my two organizers again.
Thank you, ma'am, for such an insightful session. So, just one question I had from my side. So, probably, what is your approach right now in recommending germline testing in your actual clinical practice? For the cohort of breast cancer patients you encounter, because you see a lot of breast cancer patients. So, what is the current practical thing which you're following that will be helpful for our audiences?
So I believe that we should be testing to everybody, because there are multiple things which we can find. It's a simple test, and now it is widely available, and the cost is also reduced substantially. So I believe we should be doing it. I find there is a merit in testing universally. Of course, there has to be appropriate pre-test counseling. And in
Yes.
some patients who really do not want to take that burden, they frankly say that I cannot handle that. In them we should avoid it, but document it. But in others, I think it makes sense, because we are having many things in hand. Our armamentarium is wide, and we have couple of things which we can offer them. So I think it makes sense.
Okay, thank you so much, ma'am. So I will now invite our next speaker, Dr. Lakshmi Mahadevan. So she is our genomic scientist from MedGenome itself, with over 14 years of industrial experience in genetic testing operations in oncology over Sanger sequencing, MLPA, RT-PCR. Presently, she holds the position of principal scientist at MedGenome Labs, leading the hereditary cancer portfolio. So, Dr. Lakshmi, can you take the session on and give us some insights from the lab end, so we can have enlightenment over that part also, because it is very important to actually have a good lab which can provide you these important findings, because they entirely change the course of treatment and course of all planning for such families who have hereditary cancers. Over to you, Dr. Lakshmi. Thank you.
Okay. Thank you, Charu, for the introduction and also for this wonderful opportunity to talk in this webinar. So first, let me just share my slides. So thank you for this opportunity to talk in this webinar on genetic testing in breast cancer and about moving beyond risk-based genetic criteria. So, since this webinar is about the evolving perspectives in hereditary breast cancer, so let us first just look at the changes that have happened in breast cancer scenario over the years. So, incidence rate of breast cancer has increased over the years, making it the most common cancer and the leading cause of cancer-related deaths, especially in women. In India, breast cancer accounts for 1/3 of all cancers detected in women. But much as the disease burden due to breast cancer is increasing, the drive to combat the disease is also progressing with many novel therapeutic strategies, new drugs, and more focus on targeted therapies. There is also an increased awareness among people about the early warning signals of breast cancer, the risk factors, and how they can be managed. And last but not the least, there is also a lot of technological advancements which have significantly improved the accuracy of breast cancer detection and diagnosis. But having said this, for breast cancer treatments to be effective, it's more important and very important for the cancer to be detected at an early stage. In most cases, by the time the cancer is identified and correctly diagnosed, and that an appropriate treatment plan which is tailored to the patient is made, the breast cancer is advanced to a very later stage, and then this will affect the prognosis and survival. So, for early detection, the most recommended method is, of course, the physical examination, but that only helps in early detection. For if you need to know if you for better diagnosis and better treatment methods to be applied, we need to know what is the cause of the breast cancer, and for this, screening for genetic variations is very important. Okay, so now, before we go into how these screening methods are done, let's just look at what is the genetics of breast cancer. So there are two kinds of variations that are associated with breast cancer. One is germline, which are inherited, and somatic variations that are acquired over a lifetime and not passed on to the next generation. For this reason, breast cancer predisposition and risk of breast cancer are associated with germline mutations because they are passed on to the future generations. Approximately 10% of breast cancer cases are linked to germline mutations. Now, not all germline mutations are relevant. The impact of a germline mutation would depend on several factors. Number one being the gene on which it is located. For example, if it's present in a high penetrance gene like BRCA1 or BRCA2, the risk associated with that genetic variation would be 80%. If there is a positive variant in a person, the chances of developing breast cancer is almost 80%. But when it comes to a moderate penetrance gene, the risk is about 20 to 50% and lower for the low penetrance genes. There is also another segregation or classification of germline variants, being this is according to the ACMG guidelines, the pathogenic and likely pathogenic variants, variants of uncertain significance, and benign variants. So I'm saying this because we'll be coming across these terms in the slides to come. So I'm just briefly describing them so that there is a better understanding. So the risk associated with the germline mutations, it increases with the penetrance of the gene, and also pathogenic and likely pathogenic variants are associated with more risk. Variants of uncertain significance are those for which we don't have adequate information to know whether they have a deleterious effect or not yet. So, but in future, they could go on to be identified as deleterious or as a benign variant. These are in the in between, and currently they are not considered actionable. So yeah. So now, why should screening for germline variations be done? So it helps in number one, confirming a suspected diagnosis. For example, if a patient presents with a lump in the breast, so by conventional methods to determine whether the lump is benign or it has a possibility to become malignant in the future, it's going to take time. But if the patient is tested, for variations, and it is found to be carrying a pathogenic variant in a high penetrance gene, then immediately the decision is made as to what should be the next step to be taken for that lump in the breast. Similarly, if a variation is identified, a pathogenic variation is identified in a family member, the other family members can also be tested. So this helps in assessing the risk and preventing the disease, because they can be monitored for symptoms at a very early stage, even before the symptoms start showing up. And so it helps in preventing breast cancer. Another third use of screening for germline variants is therapeutic decision making, because there are many drugs today, many treatment strategies today, which depend on what kind of variation was detected. For example, PARP inhibitors are more effective for people with a pathogenic variant in the BRCA genes. Now, this is a clinical perspective. So, from a research point of view, we would say that we get to know what is the reason that the pathogen is the cause of the cancer, what is the genetic makeup of a particular, the genetic map of a particular type of cancer, and the mutation spectrum. And these findings will help in developing new drugs and treatment strategies for the future. So, now, the next question is, now that we know what the advantages of genetic testing for germline variants and so on, next question is, who should get tested? Who is more likely to be positive for a mutation? So this is directly associated with risk factors for breast cancer, which predict the likelihood of developing the disease. So the first risk factor that we'll be discussing is age. Breast cancer generally develops in the early 30s, and the more number of affected women are seen in the age group between 50 and 65 years. The median age for diagnosis being 61 years. Then comes gender. As we all know, women are more prone than men. In 1 in 28 women have a likelihood to develop breast cancer in their lifetime, as opposite 1 in 100 males. Then the most commonly discussed risk factors was family history. So if there is a blood relative who has breast cancer or a related cancer like say pancreatic, prostate or ovarian cancer, then the likelihood for this person also to develop cancer is more. The fourth risk factor is a cluster of factors which like say lifestyle habits like alcohol usage, obesity, exposure to radiation and reproductive history. So why are we discussing these risk factors? What is their association with germline mutations? So data suggests that in the general population, the frequency of detecting germline variations is very less, like say 0.3, less than 0.3%, which means that it is the presence of a germline mutation directly indicates the likelihood of developing a disease. Now, age is another factor. About 20 to 30% of women who were diagnosed early, that is less than 45 years, are known to harbor pathogenic mutations. 10 to 30% of women under the age of 60 years, but with specific types of cancer, like say the most aggressive type of cancer is supposed to be triple negative breast cancer, and such people with such specific and aggressive cancers are more likely to have pathogenic mutations. Apart from this, multiple cancers in the same patient, same person, like say breast and ovarian cancer in the same person, also bilateral breast cancer, these are also factors, that is more than one primaries. So this is also these factors also increases the likelihood that these people will have a pathogenic mutation. Next comes family history. If there are more than four or more than four family members, blood relatives, depend again, the degree of relation also matters. But the more the number of family members who are affected by similar cancers, then the more almost 80% chance of a hereditary breast and ovarian cancer syndrome. Also, the frequency of pathogenic mutation in high risk patients, in general, what are the risk factors that we discussed? So in high-risk patients, the frequency of detecting pathogenic variants is about 20% to 33%. So this is what data show, and based on this data, because it is directly indicative that if there is a risk factor, the chances of there being a pathogenic variant is very high. So based on that, the initial guidelines were set, which I'll just briefly explain. So the age for the age criteria was determined to be 50 years. So a breast cancer developed at or before the age of 50 years is considered a criteria for testing. Diagnosed with a specific type of cancer, no matter even if the age is a little more, but the cancer is specific, like say triple negative, metastatic, or multiple primaries or lobular breast cancers, such people have a chance. So they are recommended for genetic testing. Apart from this, a personal history of breast cancer accompanied by a strong family history of breast or breast-related cancers. This is also considered an eligibility criteria. A relative with a known pathogenic variant in the BRCA or non-BRCA genes, if you have a relative like that, then you are eligible for testing. Ashkenazi Jewish ancestry, and then people with no personal history of breast cancer, they are asymptomatic, but they have a family member who satisfies the NCCN, the above criteria, then also they are eligible for testing. So apart from the risk factors, the guidelines also suggest testing for high and moderate penetrance genes alone. Okay, so this is from the NCCN guidelines. But when we follow these guidelines, the next question is, are we missing something relevant? And if so, what are we missing? So there is also several studies that suggest that up to 50% individuals with a germline mutation did not have a significant family history. There were also two separate studies in which the number of pathogenic variants out of the total number of pathogenic variants that were detected in both these studies. In the first study, 50% of the pathogenic variants, and in the second study, 78% of the pathogenic variants would have been missed if a risk-based selection criteria was followed in the cohort that was tested. And also, apart from risk factors, there are several studies that say that low penetrance genes are also detected in familial symptoms. So why then exclude low penetrance genes? So these findings suggest that call for the need to think beyond risk factor based genetic testing, and also adopt multi-gene assays, multi-gene panels, and not just focus on a few genes. So based on the newer findings, the guidelines for genetic testing were expanded and more relaxed, I would say, and more, there are two, ASCO and AS, the American Society of Breast Cancer Surgeons. They have given a more relaxed criteria, which says that the ASCO guidelines say that breast cancer at below the age of 65 years and metastatic breast cancer is an eligibility criteria. If the age is above 60 years, but the cancer type is an aggressive one, then also they are eligible. Again, these criteria also suggest testing of only high and moderate penetrance genes. And the ASBRS guidelines suggest that all patients with a personal history of breast cancer, irrespective of family history or the cancer type or the age, are eligible for testing. Patients who have already done genetic testing previously, they need to update their, like I said earlier, VUSs. They need to be looked into again whether there is any change in the classification. Also, if people who do not have a personal history of cancer, they can if they have a family member who, that's again same as what was given in the NCCN guidelines, a family member who meets the NCCN guidelines again. That's because it's the family member. So then the guidelines become more stringent. And in both these guidelines, the one common factor that was newly introduced is genetic counseling, because Now, with these relaxed criteria, more and more number of people would be included in the testing, and then there would be a lot of concerns regarding anxiety about what the outcome of the disease of the test would be, and the cost of testing is one very important factor, and several other concerns which can be like Dr. Jyoti also said, that by counseling you can talk to the patient, and only if they are willing to take the test you can give them all the information that is required, and only if they are willing to take the test, pre-test and post-test counseling is required, and then only we need to decide whether they need to take the test or not. So genetic counseling becomes an important factor when the guidelines are relaxed. Okay, so now we have two different types of genetic testing, which is broadly categorized as guideline-based testing and universal-based testing. So it's just a summary of what I've been telling till now. Guideline testing looks at a limited number of genes in a limited number of people, and who have more likelihood of carrying a pathogenic variants. There are stringent criteria. And in the universal testing, there are more number of people, more number of genes are being tested. So there is a chance to reveal the complete genetic component because more number of genes are being tested. So not just the high and moderate, we will also get to know about all the rare genes that may be involved, the cross cancer genes, like say a gene that is involved in colon cancer may be relevant in breast cancer also, we don't know. So such things, such information can be derived from a test which is more broader. Okay, so now, and more importantly, universal testing gives a chance for people who are not at risk also to be included for testing. So to get the benefits of genetic testing. So why keep them out of it? So that is one of the advantages. Now, as much as both these tests have their advantages, there is also a disadvantage that in guideline testing there is a risk of being under-tested, which we have discussed, but it is more cost-effective and avoids unnecessary testing. Some people consider it that way. Some people think that there is under-testing. For universal testing, there is increased cost is implied, and there are ethical concerns, which is a disadvantage. For the ethical concerns and the anxiety issues, and like we said, we can always include genetic testing and go for the patient's discretion on whether to be tested or not. And as for the cost, there are like we said in the first slide, the technological advancements today, like next generation sequencing, allow for multiple samples and multiple genes to be sequenced simultaneously. So this will reduce the cost, and it allows for more cost effective as well as more comprehensive testing to be possible. Okay, so now, so in MedGenome, like we all know, we use next generation sequencing for testing breast cancer patients. And we have panels that include small number of genes, like say only breast BRCA1 and BRCA2, as well as a comprehensive hereditary test panel, which has about 158 genes. So it is not, so it gives a very complete view. It includes high, moderate, and low penetrance genes, and gives a complete genetic picture about what is and it of course increases the chances of detecting pathogenic mutations because the scope is very broad. Okay, so now from the samples we have tested at MedGenome, I've taken around 10,000 samples, and of all people who were at 10,000 people who were affected with breast cancer, but with different risk factor criteria. And I have checked for the likely pathogenic VUS and no variants, the comparative analysis between people who are positive for any particular risk factor and negative for a risk factor. So what we found was that, so the PLP, I would call it PLP, pathogenic, likely pathogenic, variants, the percentage of frequencies are almost the same as what you would find. So here in an age group, I have categorized them as less than 50, age group between 51 and 69, and age group above 69. So we see that there is not much of a difference. There is a decrease as the age increases, but it is not so great that we should exclude these people from genetic testing. So if we do that, then we will be missing these positive cases. Okay, so then same for the same categories of age groups, I have also looked at the number of BRCA and non-BRCA positive cases, and there is, as you can see, between the first two groups, there is not much difference in the PLP, in the BRCA and non-BRCA variants. But in the age group above 69 years, we see that the PLP variants, sorry, the BRCA variants have come down and the non-BRCA variants. So this is in alignment with the research study that in higher age group people, the chances of detecting variations in non-BRCA genes is more. So this is basically focused on the Indian population because these patients are all Indians, and such data about Indian patients is very less. So all the papers and researches that are happening are all about for the non-Indian populations. So this is the Indian scenario, I would say. So next is the family history set, the grouping. I have grouped breast cancer people with breast cancer with the family history of breast, ovarian, pancreatic, and prostate cancers. The second group is people with breast cancer and no family history of cancer. They are only sporadic breast cancer cases. And the third category is breast cancer with a family history of other cancers, like, say, thyroid cancer or colon cancers. So in this also, we see that the frequency, the number of PLP variants has not gone down much, and even in the if there is any kind of family history, we see that it is almost the pathogenic, likely pathogenic numbers are almost the same compared to a person with no family history at all. But even then, there is a good number of people who still have pathogenic variants. Now, here again, I have also included the VUS here because there is always a concern from the clinician end whether about the VUSs, about why we report VUSs. And so definitely there will be a concern also if PLP variants are going down and VUS is increasing. So that is also not happening. So VUS numbers are also the same in all the different categories. So here again in BRCA and non-BRCA variants also there is not much of a difference. Yeah. Now this is with respect to cancer type. I've selected a few cancer types like triple negative cancers and people without triple negative cancers. And here again the mutation positivity is similar. And then metastatic and non-metastatic breast cancers also gave similar results. Then we come to male and female breast cancers. Here again, though male breast cancer is considered, since it's rare, it's considered a more risk factor than female breast cancer, but the number of variants is almost the same. But unlike the other groups, one group which gave a very astonishing result was this multiple cancers, breast cancer with ovarian, pancreatic, or prostate cancers. The mutation frequency is more than 50%, which is not seen in the other groups. So this is again in alignment with the initial, what we discussed initially, that more number of cancers in the same person increases the likelihood of positivity. Oh, so now, so this is all again a slide of the BRCA and non-BRCA variants that we detected. So BRCA1 variants accounted for 60% of the likely pathogenic variants, while BRCA2 16% and non-BRCA 24%. And here are the different types of the different genes in which we have got pathogenic and likely pathogenic variants in breast cancer cases, and some of them you would see that they are not even described in the high and moderate penetrance segments. So this is the mutation, the genetic profile of breast cancer patients which we have tested. So coming to the summary, to summarize the what we have discussed till now. Both risk-based and universal genetic testing have their own distinct benefits and challenges. Emerging technologies like next-generation sequencing and subsequent cost reductions can make universal testing or not just universal testing, any broader testing that includes more number of people and genes feasible, and this results in a paradigm shift uh, for risk-based, very stringent and limited people kind of criteria to a broader testing criteria. The role of genetic counselors becomes very critical when one moves towards a more broader type of testing. More studies, especially those focusing on different ethnic populations, like I said, we need more studies from India, or we need studies from separate populations only because the frequencies are definitely going to be different, and the risk factor also are going to be different. So we need such studies on different ethnic populations. And finally, a balanced approach which combines the advantages and then also chooses whether it chooses which is better, the cost, concerns about the cost, or detecting and treating breast cancer early. So what is more important? So that choice needs to be made, and a more balanced approach including the advantages of both the methods might be the future of breast cancer testing. So with that, I come to the end of this presentation. Thank you very much. I'll be happy to take any questions.
So thank you so much, Dr. Lakshmi. That was really insightful. It was it gave us a very important message of weighing universal testing versus the guideline oriented testing, and also we could very well see the Indian experience of MedGenome Labs testing so many samples. If you can stop sharing your screen, that would-
Yeah.
yeah. So moving on, I will come to the end of this moderation. If we have any questions,
We have a Q&A in the question box, ma'am.
yeah, we have one question, which is we should move towards universal testing for all cancer patients if there are no financial constraints. Right. Yes, I think Dr. Jyoti also answered on the similar lines, and Dr. Lakshmi also had the similar opinion with, highlighting certain challenges we might have with universal testing. So, definitely, I think the role of genetic counselors are very important in this particular scenario. If Dr. Lakshmi, you can put some light on that.
So it's mainly it shouldn't be the decision whether a person should be tested, or whether he's eligible or not for testing should not be on the person, the testing, the clinician, or the person itself should be given the chance, not based on criteria or any limitations or restrictions. It should be based on the patient's decision whether you should tell them everything about what are the pros and cons of getting tested, what are the benefits, and if they are willing to get tested, I think it's always better to leave the decision to the patient and the family.
Yeah. Dr. Jyoti, we have one question if you would like to take that. Are you there?
Yeah,
So
please tell
the
me.
the question is if you can comment on if you suggest in your clinic on the prenatal PGT testing for germline variants, because a lot of as per this participant, she is asking that a lot of patients are diagnosed with CA breast within the age group of late 20s or early 30s who have not yet planned their families. So they sometimes ask these questions whether they should do the testing or not. So what is your take on the on that scenario?
So I think we have to be very cognizant, and we have to consider multiple factors while deciding on that, and we have to have a two-way dialogue, making them understand the consequences, etc. And the patients or the families who are willing to go with that, I think it's a reasonable option. So, but they should understand the overall scenario, what will come, what will be the consequences, what options will pop up. So that all, they should not be caught unaware. That is very important. So I believe that's where there is a role of genetic counselors, which is extremely, extremely vital. And pre-test counseling, post-test counseling, everything matters. So I believe that, with that, we should take their expertise and then take final decisions.
Yeah, I think very well said, Dr. Jyoti. So, obviously, I think during for such kind of scenarios where patient is not completed their family yet and they are very early in terms of their fertility, preservation is one of the major things to be counseled, whether the patient has already, or like the individual is already diagnosed with cancer, or also is a high risk comes under high risk because he or because she is a carrier of let's say a BRCA1 pathogenic mutation. So in both the scenarios, fertility counseling with the help of particularly a fertility expert, I think should be the way forward for counseling such during the counseling also the patient should be given that opportunity to discuss it with the fertility expert.
I
So
also want to add one more thing that, I'm part of BRCA consortium with Dr. Matteo Lambertini and kind of also contribute significantly to those cases. And we found in, world over a big study, a really large study with several lead centers contributing that pregnancy in BRCA carriers is safe. So now there's long-term data available for that, which is a ray of hope. Definitely that, it is not that they cannot, but only thing, everybody who's having a stake should be involved in that
yeah.
decision making. That's what I want to emphasize.
Yeah, I think that's a very well put forward point. And being a BRCA carrier myself, I can very well relate to what you're saying here. So probably I think it's a more critical choice, and the more we talk about it, the more it becomes normal, because I think it's easier said than done. It's definitely a complex situation for the whole family itself. So there's another question. Firstly, whether we should firstly check in the index case and then the family members. So, Dr. Jyoti, what is your opinion on this? Like
Yeah,
during the
absolutely.
cascade testing?
Yeah,
Yeah.
absolutely. We should test first in index case, and if it is positive, then it makes sense to, do a family testing, and also in the family, those who are already major, so more than 18 years of age, so that they can really understand the, gravity of it.
Yeah, that's also an important point that the age criteria is 18 years and above. So I think a good point there. Another question we have. So if a person is in hereditary risk of breast cancer, can NGS itself give a certain lead to whether they will develop cancer or not? So, Dr. Lakshmi, would you like to take this one? You are on mute, Dr. Lakshmi. You'll have to unmute yourself.
So can you repeat the question,
Yeah,
Charu?
so question is, if there is a person who is who is having hereditary risk of breast cancer, can NGS itself give a certain lead to whether they will develop breast cancer or not?
Yeah, but this again, it's a very tricky question because even if a test turns to be positive for a variant, we can still not say whether the patient will develop breast cancer going forward. Even if there is a risk factor, even if there is a family history, even if they carry a pathogenic variant, there is this problem of penetrance in the genes. So not all the genes are not completely penetrant. So even if there is a pathogenic variant, we cannot say it, but then the risk definitely is increased. So we can monitor from a very early stage and take preventive measures, surgeries if required. So even if people have not started expressing the disease yet, there are no signs of breast cancer yet, but we can keep monitoring, do mammograms, and if there is any positivity seen at any point of time, we can go take a step towards like surgery or preventive measures, which will be much earlier than taking it after detecting the disease. So in that way, NGS can help, but NGS cannot predict whether a person will develop breast cancer going forward.
Yeah, so just to concise what you said is probably you can estimate the risk with the help of NGS,
Yes.
whether you are a high risk individual or not, high risk carrier or not, but whether you will develop cancer or not, that's a different story
Yeah, because
altogether.
there is generally a concept that if there is breast cancer in the patient, then they would even there are even people who expect a positive report, but and vice versa. If there is a pathogenic variant, they'll be so anxious and so worried that they are definitely going to get breast cancer. So we cannot
Yeah.
say that. We can only, but definitely the prognosis and survival rates will be much better if we get tested early.
Yes. So yeah, definitely. So doing a test and then acting upon it in the right approach with the consultation of correct guidance under having good consultative advice from the clinicians. That is what and counselors. That is what can help that individual to combat that. We have another question, which is with the increasing identification of variants of unknown significance in the genes beyond BRCA1 and 2. How do you think, counselors and clinicians should approach in communicating risk and guiding management to patients with these findings, especially when evidence on pathogenicity is still evolving? So, Dr. Jyoti, I think this is a very well faced situation in the clinic where you have a report which says, let's say, ATM or CHEK2 or PALB2 gene, but it's a variant of unknown significance. So, how do you essentially, handle that in the clinic? So, that will be insightful for our audience.
I think it's an extremely relevant question and very, very important. So basically, we should be aware that, there is some abnormality which is detected, but so far based on the current database and whatever, the reference database which we refer, like Clenvar, etc., it has not been proven to have a pathogenic significance. But please keep in mind that these data sets keep evolving. So we have to keep checking on that. And even many times the lab also, they keep informing. So we need to tell very loud and clear to these patients that right now, based on the current evidence, we cannot say that there is a pathogenesis which is kind of linked with this particular abnormality which we detected. But the space is evolving. So if this database is updated and we find this variant or so become a significant thing, then it's our responsibility to tell them later, but at that point it is not, and maybe it will never, in the lifetime. So there is always a possibility, but we have to keep checking that. And the good labs, they also keep informing because they keep checking it. It is in very busy clinics, etc. It's not possible for us to see one by one each time, but the labs, they keep seeing things and they keep us reporting.
Yeah, so I think that's a fair point.
Charu, I just wanted to add to Dr. Jyoti's answer. Just wanted to add that the current guidelines very strongly emphasize that VUSs are not considered actionable. So if there is a VUS that is reported, we are reporting it only because this is from the side of a person who is reporting. So we are reporting it only because, like Dr. Jyoti said, going forward, there might be a chance that a VUS becomes gathers evidence to be classified as a pathogenic or likely pathogenic variants, and vice versa. It could also be classified, downgraded to a benign classification. But as of when the report is generated, if the variant is a VUS, it is to be not considered actionable according to the guidelines. This is what the guidelines say. Yes.
Yeah, I think very rightly said. Both of you have given very good points around it. Just to sum it up, I think it is very important to understand, as Dr. Jyoti mentioned, that VUS will evolve and we need to update the patient. And as a laboratory, from our side, it becomes a duty that if we see any updates in it, and we are receiving, as a lab, we keep receiving these requests to review, dozens of reports together, or maybe, 6 monthly or an yearly data from centers who keep sending us consistent samples to, look at the VUSs. And it becomes very important in patients who have strong family history but are having VUSs as a diagnostic or identifier in their family, wherein those VUSs can become important further on in the family. So it is like a joint holistic effort of the clinician, lab, and the patient's awareness itself, which can answer this whole conundrum together. So this there's another question which we have. So I'm happy that people are asking so many questions. So good evening. Nowadays, many people are aware of precision medicine. However, most are not familiar how to access such treatments. Could you please let us know where the breast cancer patients can go for receiving precision medicine? So I think Dr. Jyoti is one of the expert in precision medicine, and definitely, you can go to such known experts who can guide you on what precision medicine is exactly and how you can receive it. So there is one more question for Dr. Jyoti here. Uh, the participant is asking if a mother having breast cancer in early stage but she is pregnant, would the metastatic cancer be passed down to the child crossing the placental barrier? Dr.
So I
Jyoti?
think both the questions are extremely important, and I'm glad that people are really interacting and they have questions. So the first I will take first. So the chances of in pregnancy associated cancer, which is very close to my heart, and I kind of developed this registry also in my data memorial tenure, and we kind of delivered many women and safeguarding their oncologic outcomes as well as the fetal outcomes. So, it is a trimester dependent, multidisciplinary, very precise treatment which we need to execute for these pregnant mothers when they have pregnancy with cancer. But second trimester onwards, giving chemotherapy, standard chemotherapy like anthracyclines and taxanes are safe. We don't give biologics. We keep anti-HER2 therapy, etc. later after delivery. Similarly, tamoxifen, etc. So endocrine therapy, biologics after delivery, radiation after delivery, surgery can be contemplated in all the trimesters. Which type of surgery, depending upon the trimester, because we don't want to give radiation in between. So with that kind of approach, with fetal medicine expert also in picture, we can safeguard these patients, maternal outcomes, oncology per se, and as well as fetal outcomes. Because many times we have to be very cognizant that many times these women, because of the trend, and the women are coming in 40s, and this is the first child, and practically if we give chemotherapy, we will give later hormone therapy, etc. Practically we are negating her chance to be the biological mother later. We have to be very cognizant about this fact. So that child is very precious, and understanding everything, taking everybody on board, we can take it. I'm very proud and very humbled that there are a couple of mothers who had their children. Now they are really grown up, and the mothers are doing good, the children are doing good. We have followed them up, and their milestones were absolutely normal. We have to avoid the prematurity, rather. That is one risk which is associated with their learning ability, etc. So that is important. And also we need to keep a 3-4 weeks period gap with the last chemo dose and the delivery, so that they should not go into puerperal sepsis, etc. About the first question, what was exactly that, Charu? Yeah.
Where we should go for precision
Precision
medicine.
medicine, absolutely. So, there is definitely precision medicine creeping in, and it's extremely important. It should be done in expert hand with a lot of cognizance. And breast cancer, for certain, definitely, there is a ESMO guidelines for that. How should we, really do. There is ESCO. There are other guidelines also which suggest. So, for a very simple example, even in hormone positive breast cancer, advanced diseases, if we do entire, if we do an NGS test, then we can find out that whether they are having ESR1, whether they are having, PIK3, and they are having implications on those. We know that hormone resistance can play a significant role, and how to
Right.
implement, how to, act upon that. And similarly, there are many other targets which can also be taken
Explore.
into consideration. So I'm extremely passionate about treating patients with precision diagnostics. As Dr. Choru suggested, I would be very happy to help anytime.
Sure, sir. Thank you so much, ma'am. Your take on the pregnant situation, pregnant females, and helping them in having that outcome. It was really insightful to hear. I think we have last question, which is if a patient has got pathogenic variant, which is unrelated to the clinical phenotype, and has no family history of cancer. So in such situations, what could be suggested? So
It
if you
depends upon, what we are getting in. For example, the patient has no family history, and we find a BRCA. So BRCA is a strong thing. Even if it is in cancer, which is not breast, ovarian, prostate, etc., but still, if it is a BRCA, we should not just ignoring it, and we should keep a watch, because again, as I said, this space is evolving. At a certain time point, we know that these cancers are associated with X gene, but there might be more, because we don't know everything and everything. So I think if it is clear cut it's looking like pathogenic, we have to be very cautious in interpretations, and then take again so see, if a cancer wherein the standard therapies are already present, and there is nothing to act upon that abnormality, then we should follow the standard guidelines that should give the standard therapy, but we should not completely ignore that finding, and keep watching. At times, it also makes sense to incorporate, like, if example, a BRCA, a PARP inhibitor kind of thing in maintenance. So it depends upon scenario, but it cannot be an open-ended question. It will depend upon that what cancer, what stage, many other factors.
Yes, ma'am. I definitely agree with your answer. So I think we've come to the end of a wonderful session, and I'm really happy that there was very active participation and very active discussion we have had. So I would like to thank Dr. Jyoti. It's a great pleasure to have her, and she has
And one
really.
last questions we have. One more last question we have
Oh,
come
okay.
from the
Another one. Okay, just a second. Yes. Uh,
Sure. So I think tamoxifen, the question is regarding alternate to tamoxifen. So
right,
in
ma'am.
postmenopausal women, absolutely, we use aromatase inhibitors, which is again a very, very common therapies like letrozole, exemestane, anastrozole. And even in premenopausal patient, if tamoxifen is causing significant problem, then we can use it with the suppression, with the chemical suppression, like GnRH analogs. So we can use it, certainly. Right now, there is a role of several other, SERTs, etc. is also emerging, but in very simple means, alternative to tamoxifen is certainly aromatase inhibitors.
Yeah. Thank you so much, ma'am, for having that question. So I was just, I will thank you for your time and really grateful for your presence. And I think we've had a really interesting discussion, which has really opened a lot of new gates for us to keep deliberating on. And in the end, I would just like to say that as clinicians, scientists, and counselors, our collective goal is to ensure that every woman is identified early, guided appropriately, and offered the chance to have timely intervention. And that is what we wanted to put forward in this session, that preventive oncology truly it begins with a single gene, but it can end with a life saved. So thank you so much. Have a good night, everybody, for giving the attention today. Cheers. Thank you. Bye bye.
Thank you very much. And I think kudos to all of your efforts also. I think it should be a regular event. Thank you very
Yeah,
much.
definitely, ma'am. Definitely. Looking at the deliberations we had
Participation and
today,
your
we
interest.
should start a series also. We can do that. Thank you, ma'am. Thank you,
Please
Dr.
take care.
Lakshmi, for your
Thank you.
kind presence. Thank you.
Thank you very much.